Thanks, everyone. Wonderful to be here with you tonight. I am not gonna say much by the way of who I am. I'm kind of tired of hearing about who I am, and I'm more so tired of speaking about it. But I will just say that I work in primary healthcare. I treat a lot of trans and gender diverse patients, and always just looking for ways to do better. And I think kind of the guiding principle for me is, as much as I aim to provide a comprehensive, safe, and accessible service, I also desperately don't want to have the monopoly on that. So the more people who are able to do this work, the better it is, as far as I'm concerned. I will put out a quick proviso just to say that I seem to be experiencing intermittent technical difficulties here at the home base. So if I drop off the call, please do be patient. I will reconnect, whether on a computer or a phone or whatever it is. So please bear with me. And then if I can just ask from either Chris or Alma, how much time have we allocated for this discussion? Anyone?
We
Chris, Alma?
usually go until about 8:30,
Oh,
including questions. So
right. Okay, that's fine.
if you
I
want to
just
speak till 8, and then there's usually a lively discussion.
Okay. All right. Well, we'll see. If I haven't bored you all to tears or death, I'll aim to wrap up around 8, and then we can have the lively discussion thereafter. Um, Please do interrupt me if you have questions. That's the first thing. The second thing is just to say that in addition to being woefully underprepared, I'm also woefully underprepared. So I don't have slides for you. I am going to keep this discussion very dynamic, and I think that that makes sense given what we are discussing tonight with regards to how do we manage non-binary care. I don't think it makes a lot of sense to stick between any predefined margins. To that end, I would very much value your participation. Anyone who's heard me speak before knows that I like to engage with the group that I'm addressing, and tonight will be no exception. I am also very much a proponent of consent. So I'm not going to pick on you or call out names. Please don't be shy, unmute, put a hand up, type in the chat box, whatever it is. But if you can contribute to the discussion in that way, I will be very grateful, and it will enrich the discussion for everyone. Having said all of that, now that I've bored you with the ground rules, I think as a point of departure, so we're speaking about our role as various healthcare providers, members of the multidisciplinary team in facilitating, navigating, and educating when it comes to care of the non-binary patient or client. And I think the starting point there is for us to understand, well, who are we talking about? What does this mean, non-binary? And I'm going to put that to the group. What do you understand by the term non-binary? What does that mean to you? And I'm specifically asking, what does it mean to you? Which means not what is the dictionary definition or the WHO definition or the gender dynamics or the Aranti definition. So no wrong answers here. What do we understand? Anyone who wants to volunteer or jump in to say, what do we understand by the term non-binary? We see it, we use it. What are we talking about? Any ideas on this? Come on, team, don't make me do this all by myself. Kevin, I see you've unmuted. I'm taking that as that you want to answer. Kevin's muted again. Anyone else want to take a stab at this? Ron.
Hi, Anastacia.
Hi.
So non-binary for me means that my sense of my gender identity does not fit into the two typical binary options of male and female, masculine or feminine, that it may be a blend, a combination of elements of masculine or feminine and outside of that as well, but definitely not fitting in the binary.
Okay, excellent, excellent. I think that's really central to the discussion. And hopefully one day, perhaps another time in the curriculum, I'll be able to go through with you kind of the concept of biological sex, the concept of gender, how we come to all of it. But Ron, you've really hit the nail on the head. I'll come to you in one moment, Nicole, bringing in this concept of the binary, male and female, and I think masculine and feminine were the words that you used. Nicole, over to you.
I definitely don't want to make it seem as though I disagree with Ron, but I wanted to add that the one thing that's pertinent for me when it comes to the understanding of non-binary is that it could also encompass the rejection of the concept that certain traits are masculine or feminine, and that there is a need for there to be a binary. So it could be, I feel, a blend between the two, or it could be, I reject the notion that they fit into these neat categories, one assigned to, and then each category having certain characteristics. I hope that makes sense.
Absolutely, absolutely. So maybe breaking some of the rules that we associate with male and female men and women. Pierre, your hand was next.
Yeah, thanks, Anastacia. And in fact, I think Nicole sort of summarized it quite well, which is I increasingly find the definition of what we say as male and as female are essentially constructs and feel fairly arbitrary. I know we try and layer them onto this idea of binary bodies, but I really do think that those categories and those ideas about what is masculine and feminine are fairly arbitrary. And I reject them personally in my own life. And I think also there's something sometimes slightly problematic about defining people as non. It feels something, a deficit kind of model. So is there another way to frame this, that it's about what people are rather than what they are not?
Excellent. Yeah, some really great perspectives coming through there, Pierre, and thanks for challenging us on the language, because I think that's important. I'll come back to some of what you said. Let me go to Kevin. Kevin, you are unmuted, but I can't hear you. And I still can't hear you. Kevin, I think maybe having some problems with the microphone. All right. Kevin, please do keep trying, because I would love to hear what you have to say. Anyone else who wants to offer a perspective in the interim? So I think we've heard some very sort of useful insights and reflections on what non-binary identity is. And Pierre, I really, really love what you said about how we're defining identity kind of by what it's not, rather than by what it is. And I think that you've really identified one of the core components in what makes gender-affirming healthcare in its current state deficient. And that's so much historically, and I mean, I'm not talking about all of the wonderful members of PAFISA, but it is so much based around the idea that a trans body is defective, and that the way to correct it is to make it resemble more closely in form or in function a cisgender body. Now, when we understand or think about cisgender bodies, particularly from a medical lens, we tend to do it through this notion that everyone is either male or female, biologically speaking. As I alluded to a little bit earlier, hopefully one day I can explain to you why that isn't necessarily very scientifically accurate, and how it's a gross oversimplification where we're actually taking a concept and simplifying it to the point that we become completely incorrect in our understanding of it. But having said all of that, we have this binary concept of sex being male and female. We extrapolate from that a binary understanding of gender as masculine or feminine, man and woman, and we try and fit people into this mold. And then we go and we take a term like non-binary, and we say, well, these are the people for whom those two boxes do not fit. And this goes against the classical model of a trans person wanting to transition from one sex to the opposite sex. And even saying words like opposite sex, highly problematic in that regard. Just a note on the language is that perhaps in 5 or 10 or 1 year from now, we will no longer be speaking about non-binary. Perhaps it will be replaced by another term. But at the moment, this is the vernacular and the language that's in use. And I think it's very important for us to realize that when we try to define what a term like non-binary means, we should always recognize that if this is not something that applies to us, this is not our lived experience, we have very limited, if any, authority in trying to define what it means. So for everyone who's contributed and who's said that there's some aspect of their own identity or their own lived experience that exists outside of the binary, you get to shape that definition. It is the non-binary people in society. It is ourselves, perhaps, if that is applicable to you, or it is our friends, family members, certainly our patients. So understanding this and recognizing that people who do identify as non-binary do not necessarily conform to some of the rules or some of the preconceptions that we have around sex and gender, and also recognizing how those preconceptions have, up to this point in time, shaped the provision of gender-affirming healthcare, we can start to see where some of the shortfalls arise. Because if we have a model of provision of healthcare that says, all right, we're going to take someone who was assigned X at birth, and we're going to try and replace their endogenous hormone profile with that of someone who was assigned Y at birth, for example, or we're going to perform surgical procedures to more closely align that person's anatomy with someone who was assigned differently at birth, we realize that what we're trying to do is we are, as I said earlier, trying to fix a transgender body by making it more closely resemble a cisgender body. Now, what's important about this is that it means the reference point, the framework that we see it through, is through a lens of what someone is not, and the assumption that that is what they want to be. And we see this play out with intersex infants, with babies whose genitalia cannot be very neatly delineated at the time of delivery, usually by the attending medical professionals, into the category of penis and scrotum or vulva. And we know that it continues to happen around the world. Certainly it does continue to happen in some parts of South Africa, I'm convinced of, is that parents are often coerced into consenting to surgical procedures to correct, and please hear the air quotes there, correct these anomalous genitalia. Does it make the intersex individual's life better to have undergone an irreversible surgical procedure before they're even old enough to understand what it is, what it entails, what the consequences might be, or to consent to it? No, but it certainly makes us at darn sight more comfortable. So this is what we need to move away from. And what's challenged clinicians over the years when they see non-binary patients is to kind of know what to aim for. Because if we are no longer aiming at a certain set of hormone levels or surgical procedures or multidisciplinary referrals and interventions, then we start to feel a little bit lost in what we're doing. So, on that note, I'm going to introduce to you a concept that I coined while I was driving home from teaching my UCT students this afternoon, having a little conversation with myself about what is it that I'm going to try and speak about this evening. And this concept that I'm going to introduce, and I'll just take a moment to align all of the words correctly in my head, is a goal-orientated, collaborative approach to healthcare, or rather to gender-affirming healthcare. Now, there are a couple of limitations, and what I want to put out there, so I say it's goal-orientated, and part of understanding what I mean by goal-orientated, and perhaps I'll change the way that I refer to it as I refine the concept, but when I say goal-orientated, what I advocate, Tabang, I will repeat it for you. I'll even put it in the chat box if I can coordinate myself to do it. But the concept that I'm speaking about is the goal-orientated, collaborative model for gender-affirming healthcare. And when I say goal-orientated, I think what's important to understand here is whose goals are we speaking about. So as I mentioned before, when it comes to intersex children, we often subject them to operations with the goal of making their anatomy more closely align with someone who is not intersex or someone who is endosex. Now, as I said to you, that isn't necessarily the individual's goal because the individual is often too young to decide. We do it with our adult patients, with our trans patients. We have our own preconceived ideas of where they need to end up. And when I speak about a goal-orientated approach, in order to identify the goals, we have to have a conversation with the patient because we're not speaking about our goals. We're not speaking about society's goals. We're not speaking about the Department of Home Affairs goals. We're speaking about the patient's goals. What is it that they hope to get from interacting with us and accessing some kind of gender-affirming care? Because those are the needs that we need to be meeting. Now, in this day and age, we see a variety of patients. They come from a lot of different backgrounds. They have a lot of different levels of education, different kinds of socialization, access to different levels of resource. Some of them have a greater understanding of some of the interventions that health and allied professions can offer, and some of them don't. And this is really why the conversation is very important. So for me, the starting point when I see a non-binary patient is to understand what is it that you're hoping to get out of this exchange. And there's a number of different ways that we can do it. We can phrase it as simply as I have just now, or we can say, how can I help you? Or what is it that you're hoping to gain from this consultation? What are your expectations for your interaction with me? And by doing that at the outset, we are able to ensure that we are not putting the cart before the horse, but that we are on the same page with the patient or with a client. Having said that, the overarching sort of fundamentals that we bring into, I would hope, any consultation with any patient, but especially with patients in the LGBTQIA+, and especially transgender or gender diverse patients, is that we should try and endeavor, of course, to show respect for people's names, for their pronouns, for their bodies, for the language or the words that they're comfortable in using or being used in reference to those bodies, and we should make no assumptions. So these are general concepts. I'm not going to spend too much time going through them tonight because I don't think it's within the scope of our discussion, but I do just want to put it out there that we need to bring those same concepts that I hope we all, as members of this organization, already know and embody. So identifying the expectations and the goals. Now, for a lot of patients, they'll come with a specific list of things that they are hoping to get out of this. I want to be rid of breast tissue. I want to grow facial hair. I want my voice to drop. I want my skin to be softer, or whatever it is. For some people, the goals might be less well-defined, but still very important. The goal might be, I want to feel more comfortable in my skin, or I just want to feel better, or I want my dysphoria. Remember, not all patients have dysphoria, but I want my dysphoria to be eased. Now, this is where we sometimes have to do the not altogether pleasant task, but certainly a responsibility of being a professional working in healthcare with the skill, knowledge, training, and experience that we have of managing some of those expectations. So the first thing that we need to do is to open the discussion. We need to facilitate it. If patients aren't understanding the question or aren't able to answer it, find ways to better communicate what it is that you're seeking to patients. So I might ask my patients, if I'm not getting to the answers that will help me to guide this process, then I might say, is there anything specific in terms of physical features or in terms of emotional experience or in terms of physiological processes, think like cyclical bleeding, that you would want us to address? Now, this is where the managing of expectations begins to come into it, because sometimes patients will think that we can do things that we can't do. So if someone says to you, well, I want to go on to gender-affirming hormone therapy, or I want to go on to estrogen, and my goal is that I want to not have facial hair, there's a bit of a disconnect there, because I know as a medical doctor that going on to estrogen doesn't get rid of facial hair. So I'll have to have a conversation around and manage some of those expectations. Some of our patients will come with expectations specifically around what kind of interventions it is that they are seeking, whether it be surgical or medical, top surgery, bottom surgery, orchidectomies, hysterectomies, that sort of thing. Or some patients will say, well, I don't want to go on hormones, but I want to go on blockers. Again, managing these expectations becomes important, because the people that we're interacting with don't necessarily have all of the understanding of anatomy and physiology to know what's possible and to know what's not possible, and to know what's safe and to know what isn't necessarily safe. So this is the point in the conversation where a patient might begin to say to you, well, I thought about going on a low dose of estrogen, or I thought about maybe just going on to anti-androgens, or I thought about going on to estrogen blockers, whatever the situation is. We need to understand these expectations, and it helps to do it at the beginning of your consultation with your patient, so that it can help to inform the rest of the conversation that you have. We are all busy professionals. We don't have infinite time to spend with our patients, and we do have to use the time that we have wisely. So my first piece of advice, my first practical approach under this collaborative, goal-orientated model for gender-affirming care is to identify and, if necessary, manage the expectations that a patient has. The next point that I want to address with you, once you've had this conversation about what are the goals, what are the things that a patient wants to achieve, from the interaction with you, and of course, passing this through the lens of what is possible, what isn't possible. And just to further elaborate on this, in some instances, patients will have an idea that they're going to go onto hormones for a fixed period of time and then possibly come off of them. In that instance, it becomes very important to have a conversation around, well, which of the effects that the hormones will result in are reversible and which ones are irreversible. And the way that I explain this to patients, when I speak about, we again, I'm going to touch back on what Pierre said earlier, in terms of which way we orientate our language. Are we using positive language or negative language? When I counsel patients about going on to gender-affirming hormone therapy and what it does and what it doesn't do, and the risks and the benefits and the potential side effects, when I speak about effects that are reversible and irreversible, I frame the conversation a little bit differently. So we common logic, or not common logic, but let me say that the majority of healthcare providers that I interacted with on my own journey used to frame this as these are the things that will happen to you if you go on hormone therapy. Some of them are irreversible. Are these things that you really want to happen? I frame it the other way around, and I say to patients, irreversible effects from hormones means that you'll be able to retain those changes even if you discontinue your hormone therapy. Things like the development of facial hair or the growth of breast tissue. Reversible effects are things that you will need to stay on your hormone therapy if you wish to retain. So rather than saying, these are the things that will go back to normal if you discontinue your hormone therapy, which again uses not being on hormone therapy as the normalized baseline for people, I frame it the other way around. So I think that the framing is quite an important aspect of having this conversation with the patient, because it immediately sets the tone for whether that engagement is going to be collaborative, and remember the collaborative model, or is it going to be adversarial? Sorry, I do have notes in front of me, so I'll just pause while I reflect on what I wanted to say. All right, so the first step in managing the non-binary patient, navigating care, is to identify the expectations, manage them if necessary. This can lead into a position where you might have to detail for patients kind of what the options are that are available to them. Because if they haven't come in with a preconceived notion of this is where I see my treatment going and these are my expectations, then you might have to describe for them, these are the ways that we can affirm or offer interventions to affirm your experience. I find it helpful to classify those as hormonal or medical interventions, as surgical interventions, and as allied health interventions. This is where physiotherapists and dietitians and speech therapists and other disciplines play a role. And then, of course, supportive interventions, the domain of, or let me say supportive to mental health interventions, the domain of therapists, psychologists, counselors, and so on. Once we've got an understanding of what it is that a patient wants, and we have reconciled it with what is medically possible, then all of the same fundamental basic tools that we use in our interactions with any other patient, including the binary identified trans patients, the history taking, the physical examination, the discussion around fertility, the laboratory investigations, the referrals to allied health, come into play. So this is really where we begin our role as navigators and conductors, if you will, of gender-affirming care. This is where we use our skills, our experience, our networks our professional associations in order to connect the patient to the kinds of interventions that will help them to achieve their goals. So again, if a patient comes in and says, well, I just want to feel better about myself, then your discussion is going to lead you into, well, what are the things that are preventing that? Is it anxiety or depression? Do you need to see a psychologist? Do you need a psychiatrist? Is it around cyclical bleeding? Do we need to prioritize switching off your cyclical bleeding in order to improve your quality of life? Is it around certain physical changes? And if it is, then how do we attain those physical changes? Recognizing that certain combinations might be possible, certain combinations might be impossible, and that all of the time we are forever at the mercy of a patient's genetics, which we don't know from looking at them or from taking a history or doing a physical examination. And we are at the mercy of time. Certain processes do just take time. And that all comes into that managing of expectations. Once we've done all of the groundwork, this is where we start to collaborate on the plan. So we've put it all out there, this smorgasbord of options that patients can have. We can facilitate hormonal intervention. We can facilitate surgical intervention. We can facilitate referrals. Now it comes to, let's set a plan. What is it that we're going to do? How are we going to get the investigations done? What kind of medication, if we're putting you on medication, are we going to prescribe for you? Is it going to be pills? Is it going to be injections? Is it going to be topical treatment? Which professionals are we sending you to? And then most importantly, I want to say, is our framework and our strategy for the follow-up, because this is a longitudinal, that was the word that I left out when I was trying to piece together a title for the model, is that it has to be longitudinal. It's not something that happens at a singular point in time. Whatever we decide with a patient, whatever plan we collaborate on, whatever goals we have set for ourselves during this interaction or consultation are subject to change. And the agency and authority over how they might change is the patient. And it's important to put that out there and to say, when you set your schedule for follow-ups, if any of this changes in between now and then, please let me know. Otherwise, let's revisit this when you come for your follow-up. So for me, as someone who is a prescriber of hormone therapy, I will see a patient on day 0. We will do whatever baseline investigations. We'll get started on whatever interventions I'm prescribing. And I will see a patient for a follow-up at 1 month. I will see a patient for a follow-up at 3 months, again at 6 months, and then 6 monthly thereafter. And at each of those patient contact sessions, I will check in and say, what have we experienced in terms of the changes or the goals that we were pursuing? What effects has the intervention had? How are we feeling about them? And what are our priorities in moving forward? So maybe top surgery wasn't a consideration, and now it is. That's fine. We can update our plan. We can go back to that mind map that we facilitated of networks and referrals in order to access resources that maybe we didn't think were necessary. This is a longitudinal approach. It can change. It is dynamic, just as people's identities or their understanding of their identities is dynamic. So when we manage those expectations, when we set those goals, we need to also bear in mind that we create a space and an understanding with our patients that nothing needs to be set in stone. And we can revisit this on a schedule, but again, at any time, sooner or later, should it become necessary. I'm going to take a sip of water. Let me break for a quick moment and just see if there's any questions that I need to address. before I continue? I'm going to take that as a no. All right, so we have an overarching model for our interaction and our consultation with the non-binary patient. We have an approach that is goal-orientated in terms of we want to achieve certain outcomes, whether they are easily defined or whether they are more vague, they are all valid. We have a process where we manage, first identifying, but then managing those expectations, where we lay out the kinds of interventions, support, and treatment that is available to our patients, the nuts and bolts that apply to every interaction with the patient, whether it's a physical exam or a mental state exam, however it relates to your profession, and a strategy and a framework for following up. This is all governed by an approach that makes no assumptions around what people want, that shows respect for people's autonomy and agency with regards to names, pronouns, language, bodies, and everything else. Excuse me. And one that is based on an informed consent basis, those overarching principles that we apply to most everything that we do, or that hopefully we apply to most everything that we do. The other things that I want to touch on very briefly before we open for further discussion, and I know that I've given you a very broad framework, and I didn't want to zoom in too much on what it is that we do with hormones, or what it is that we do with surgery, or what it is that we do with mental health, because I wanted to keep this accessible to a variety of people coming from different practices and professional backgrounds. So it's not to say that none of that is important, and I'm happy to answer questions if there are, but I also wanted to keep this as broad and as accessible and as generalizable as possible. I do want to touch on monitoring when patients come for follow-ups, because we often do blood tests for them, and there's always a question around, well, how do we interpret these? What do we do when it comes to reference ranges? And I'm going to introduce here a concept, or just the idea that I'm sure you're already familiar with, but that when it comes to follow-up and monitoring, it shouldn't all be based on laboratory metrics. We should also think about how do we introduce objective measurements for non-laboratory metrics and outcomes with regards to mental health, satisfaction, quality of life, physical changes, and so on. And this is particularly important when it comes to gender-affirming healthcare, and especially medical gender-affirming healthcare, because patients tend to look in the mirror each and every day, and it can be very difficult for them to see what is changing and what isn't. So introducing a structure, much like we would with a mood or anxiety tracker or a migraine diary or some kind of structured framework, is very, very important here. The current guidance on actual laboratory reference ranges is to use ranges that are appropriate to cisgender people of, let me not get bogged down in the language. The approach with reference ranges is that for patients on masculinizing treatment, we should use reference ranges applicable to cisgender men. For patients on feminizing treatment, we should use reference ranges applicable to cisgender women. What are the non-binary ranges? We don't know. Will we ever know? Probably not, because people want different things. And this is why at this point in the conversation, I'm going to remind you that the point of having this discussion around goals and desired outcomes is to preserve the autonomy and the agency of our patients. Not to meet our expectations, but to try to meet theirs when it's reasonable to do so. We have to ensure that we do it responsibly, effectively, and above all else, safely. So this is why I have a conversation with my patient who comes in and says, I don't want to go onto estrogen, but I do want to go onto a high dose of sapropterin acetate to suppress testosterone. I have to have a conversation with them and say, well, adequate levels of one or another sex hormone are necessary for the maintenance of your cardiovascular health, of your skeletal health, of your mood and energy levels, potentially of your libido, if that's a thing for patients. We have to have an understanding of what is safe and what isn't safe. So we know that having 0 or near 0 levels of testosterone and 0 or near 0 levels of estrogen at the same time is not safe. We know that having sky-high levels of testosterone is probably also not safe. We know that having high levels of estrogen, depending on the dosage form, is also not safe. So this is where, when we interpret these results, we should not get too bogged down on whether our non-binary patient is meeting the reference ranges that we have in mind for our cisgender patients, but rather to approach it from a perspective of, is this safe? Is this effective in meeting the patient's goals? And where are we in terms of the patient's lived experience? That should be the guiding principle for us. That's all I'm going to say on laboratory measurements and monitoring. The next thing I'm going to talk about very briefly is just screenings in terms of health. What kind of screenings do patients need to go for? A lot of this does appear in the SAHIV Clinician Society guidelines, but screening should be informed by anatomy, physiology, and lifestyle. What do we need to screen a patient for if they're assigned female at birth? We don't know. We don't know. Cervical cancer? Maybe. Breast cancer? Maybe. We don't know. So everyone wants to know about what screenings do we need for non-binary patients? You have to put in the work. Have the conversation, develop the relationship with your patient, and advise on screenings as appropriate. That's me on screenings. I did say to you already that the process needs to be a longitudinal one, that we reassess as necessary and on a schedule. And then the last thing that I want to say before I open up, sorry, I promised you an interactive session. I've just been yammering. We'll try and fix that in the next half hour. The last thing that I want to say, this is a line that I find myself repeating to my patients over and over, because they sit in front of me and they kind of want me to map out a trajectory for them. And I say to them, the point of putting you on hormone therapy, and this is applicable to whatever gender-affirming intervention, I speak about hormone therapy because I do a lot of it. The point of putting you on hormone therapy is that your life should be better on hormone therapy than it was off hormone therapy. And if that isn't true, we need to reassess what we're doing. And if that was true but is no longer true, we need to reassess what we're doing. But at the end of the day, I have no vested interest in whether a patient is on or off any kind of treatment, which interventions they want or don't want. My vested interest is in making sure that I'm using my knowledge, my skills, my experience to oversee that process in a way that is as safe as possible, as efficacious as possible, and that it's actually making some kind of improvement to a patient's life. So for us, prescribing gender-affirming hormone therapy, maybe we want to measure our success if we're prescribing, for example, estrogen. Maybe we want to measure our success in cup sizes. If we're prescribing testosterone, maybe we want to measure our success in centimeters when we measure clitoral tissue. I don't measure it. You shouldn't be measuring it. No one should be measuring it. These are not good metrics for success. And we need to realize that as clinicians. So what I said to you all the way at the beginning of our discussion about making no assumptions is we need to understand where a patient is and what it is that they want. Some of these things are variable. I say to patients, oh, a side effect of this medication is that it could suppress your libido. Some of them are overjoyed. Some of them are very distraught. Don't make the assumptions, and don't think that the conventional metrics or the metrics that you by instinct want to refer to are necessarily the same as those of the patient. So there you have it, team. A collaborative, goal-orientated, longitudinal approach to navigating gender-affirming healthcare for non-binary patients. Hopefully at some point I'll be able to distill this down maybe into a set of slides or something, but in the interim, I do have a couple of online resources that I found, which I will ask sorry, my cat is up to something while I'm trying to present. So I do have some resources that I will ask the secretary and chair to distribute to the rest of the members after the fact that you might find helpful. And I look forward to a discussion, comments, insights, reflections, and I apologize for just going off on a tangent and speaking myself into oblivion without giving you an opportunity to put up your hands or engage. I feel like I got off to a very good start picking on people, and then I let you all down. So I apologize. If I am invited back again, I will endeavor to do better. I'm going to mute and hand back to someone else to facilitate the next steps in our discussion.
Thanks, Anastacia. And yeah, what a lovely new model that we can think around.